Good evening, everyone. We're so thrilled to have you back for our annual flu time presentation. This year, we're calling it Flu plus RSV plus COVID and more. And it's a practical review for everything for flu season 2023. Hopefully, you know some of us already, but I'm joined tonight by Dr. Molly Yang, who's our Director of Pharmacy Innovation and Professional Affairs at Whole Health. And there's myself, James Morrison. I'm Director of Pharmacy Excellence at Whole Health. That's, supporting the operational needs of our pharmacies across Canada. And we have the pleasure of having Miriam Imran joining us as well, who's a PharmD candidate from the University of Saskatchewan, who's on placement with us here at our head office remotely for about 2 months. And we're really happy to have Miriam joining us tonight. A little bit about Whole Health before we soldier on. Whole Health is an independent pharmacy banner, and we're still the new kid on the block. We're about 7 years old, with about 200 locations across Canada and growing. So if you are interested in Whole Health for your own independent pharmacy, or maybe you're thinking about opening a pharmacy, please reach out. We'll go to the next slide, Molly. We're really fortunate to have support from our partners, and tonight specifically, GlaxoSmithKline has provided financial support towards this presentation, and we're really grateful to have them as one of our key brand partners. Thank you, GSK.
Yes, and I just want to note that although we do receive lots of support from many of our sponsors, a lot of our education, the content we create in-house, so it isn't influenced by the sponsor at all, especially not tonight.
Yeah, absolutely. It's an unrestricted educational grant, so the brand partner had nothing to do with the development other than sharing us information about the new vaccine, which we're all interested in. So tonight's agenda, we're going to start with flu. So reviewing some recommendations for flu for 2023, 2024. We're going to talk a little bit about RSV and the new vaccine RXV. It's really exciting to have the first vaccine to address RSV available in Canada. And we'll talk about, which of your patients might benefit from that vaccine. The next topic will be COVID-19 vaccines. We've got a new COVID vaccine coming out and arriving in our pharmacies any day if you don't have it already. And then also about Paxlovid treating COVID-19. We're going to talk about other immunizations for key populations that you can recommend and support your patients during this respiratory season. Best practices and tips and recommendations around providing immunizations. And lastly, vaccine recommendation summaries, opportunities, and pharmacy workflow tips.
Okay, perfect. Thanks so much, James. And as you can see from the agenda, we have a lot to go through, and similar to other whole health content, we try to be as practical as possible to help our pharmacists and everyone on the line, on the front lines, in providing these recommendations to your patients. I've copied this chart from our presentation last year and added RSV as well. And I wanted to put this here just to show you that there's a lot circulating this flu season. And from what you can see, often going just by symptoms alone, it can be often unreliable, right? And different sources will also say different things. Frequency will vary. Each patient is different. So again, symptom-based identification, often unreliable, which is why prevention is so important. So we'll go into a quick review of flu first. We know that there are two main types, influenza A and B, and A makes up the majority of circulating strains. And unfortunately, these strains are constantly mutating. So that's why we require annual vaccines. In terms of why flu is dangerous, you have both the direct respiratory effects of the infection that we're all aware of. However, there are also serious indirect effects as well as triggering and exacerbating various conditions. For example, 1 week after influenza, your acute MI incidence is 6 times higher, and your heart failure hospitalization is 34 times higher. You also have increased complications with CKD and diabetes, and not to mention the functional decline from these direct and indirect sequelae. In terms of who's at risk according to NACI, I know this is a review for many on the line as well, but we'll quickly go over it. Of course, we have young children, pregnant individuals, individuals with chronic health conditions, older adults especially as well, and residents of group living, as well as Indigenous peoples. We also have people who are in close contact with these high-risk individuals, in which it would be important to protect them against influenza infection as well. So that includes service workers, childcare, healthcare professionals, as well as household contacts. In terms of why older adults are at such higher risk, contributing to the majority of flu hospitalization and deaths, you have a combination here in older adults where their tissues are more susceptible to infection, plus you have a weaker immune system with age, plus a weaker response to the immunization as well. Therefore, it's important to protect our patients with the vaccine. And here's a summary with some changes from last year. The main change is around Influvac, which NACI is now recommending for ages 3 and up instead of 6 months and up. In terms of the available vaccines, we have 2 main categories: the quadrivalent, which includes 2 A strains and 2 B strains, and the trivalent with 2 A strains and 1 B strain. So we won't go through all of these details on here. The slides will be sent out after the presentation, so you will receive this, no worries. All of these vaccines are 0.5 milliliters in dose, except the Fluad pediatric, which is 0.25 mils, and the Fluzone high dose, which is 0.7 mils, and the Flumis, which is 0.2 mils or 0.1 mil per nostril. In terms of a frequently asked question that we get is egg allergy. So egg allergy is not a contraindication for influenza. However, if there are situations where patients definitely can't get a vaccine with egg in it, the Flucelvax and Supemtec are completely egg-free. So with that, I'm going to pass it on to Miriam to go over these next 2 slides.
Hi, everyone. Okay, so across Canada, there are 6 influenza vaccines that are publicly funded, depending on which province one is in. The first 3 are the standard inactivated quadrivalent vaccines. Both the Fluvac and the Fluzone is indicated for individuals 6 months and older. Fluvac and Fluzone are publicly funded more widely across Canada compared to the Alpharia Tetra vaccine. And it is also to note that the Alpharia Tetra vaccine is eligible for ages 5 years and older. Then we have the Fluzone high-dose influenza vaccine. This is also widely publicly funded across Canada for those 65 years and older. However, in some provinces, the high dose may be reserved for those living in long-term care, assisted living facilities, and First Nation communities. Then we have the Fluad influenza vaccine, and that's eligible for 65 years and older. And according to our findings, it's currently publicly funded in BC and Ontario. Lastly, we have the Flumist intranasal spray. It's publicly funded in BC and Quebec, and in PEI is publicly funded through public health clinics. It's eligible for ages 2 to 17 years of age, and individuals between the ages of 18 and 59, if they have needle phobia or if they're unwilling to get another influenza vaccine, then they may be eligible for the Flumist nasal spray.
Thanks so much, Miriam. And as Miriam went over, there are pretty big differences between certain provinces in terms of what's covered and what's not. And in addition to differences between what's covered, there's differences in start dates as well. So some provinces will have a coordinated start date. So please make sure to stay tuned within your own province to be able to start at the right time. And often these programs will often begin with high-risk patients as well.
So here we have a good visual representation of the age groups that may receive their flu vaccines at a pharmacy. In some provinces such as Ontario, New Brunswick, and Nova Scotia, both the pharmacist and pharmacy technician can administer the influenza vaccine. In Saskatchewan, pharmacy technicians have been temporarily authorized to administer the flu vaccine. due to the emergency order. And we can also see that in Northwest Territories and Nunavut, flu vaccines are only being administered at public health clinics.
Okay, so one of the most common questions that we get from patients as well, and that we get at head office from our pharmacies, is around the choice of vaccination. Now, there's limited data that's available directly comparing these flu vaccines, and really not much has changed from our recommendation from the previous year as well, but we'll go over the age groups. So for ages under 2 years, we have the standard dose quadrivalent. If patients are 2 to 17, they can get the standard dose quadrivalent or live attenuated quadrivalent, so the FluMist. You can also consider FluMist for ages 18 to 59 if patients are needle averse. For adults 18 to 64, there's a standard dose quadrivalent or the recombinant quadrivalent, which is Zupemtec, which you may consider, especially for patients 50 plus with comorbidities. And within the 65 plus year range, that's where we have multiple products available. And our recommendation follows that of NACI's, which if available, the high dose should be used over standard dose. If that's not available, you can use the adjuvanted trivalent. Even though it's trivalent, which means it has one less B strain, the adjuvant may provide more immunogenicity for influenza A, which, if you recall, is the most common and important one to cover for. If that's not available, you can also use the recombinant quadrivalent, but of course, there's no coverage for that across Canada. And if none of those are available, then the standard dose quadrivalent is a perfectly good vaccine option as well. The overall recommendation is, whatever you have in the pharmacy, to give that to the patient and to help them understand that all of these vaccines are good options for them. In terms of patients who are 2 to 9 years old, they need a second dose after 4 weeks. So it's not just one dose, they'll need to come back after 4 weeks if this is their very first flu shot. If they had a flu shot in the past, they only need one. Okay, so with that, that was our review of flu. If anybody has any other questions, please feel free to put them in the Q&A or the chat. We're going to move on to the hot topic of the day, which is RSV, which everyone is interested in at this time. We hope that after this section, you'll have a good idea of how to talk about RSV with your patients and feel comfortable with protection methods as well. So RSV is a respiratory RNA virus that circulates during the same time as flu season, so October to May, peaking in December. It's very contagious with an R0, which is a reproduction number, which means the average number of people that one person who's infected will then go on to infect. So it has a high number of 3. And for context, the R0 for flu is about 1 to 2. For COVID, it can vary depending on the variant, but usually around 2 to 3. And the risk of recurrent infection with RSV is also very common. We'll go into some symptoms on the next slide, but generally after getting infected, symptoms will appear after 4 days, and infected individuals may be contagious before they experience symptoms, and then that can last for about a week or so. But in older adults, and especially in immunocompromised individuals, this contagious period can last for a lot longer. And, when we think about how RSV has been presented in the past, it's often thought of as a pediatric illness because the incidence in adults is low, but it is associated with a substantial burden in older adults, and especially those with risk factors. So risk factors include, of course, babies under 2 or older adults over 60, patients with comorbidities like diabetes, heart disease, lung disease, CKD as well. Individuals living in group settings like long-term care, and individuals who are immunocompromised. So this includes due to a condition, so a medical condition causing immunocompromisation, or due to medications. So often we forget about things like biologics for psoriasis, for example, can also cause patients to be immunocompromised. And these are all independent risk factors that build upon each other. Within older adults, we see a perfect storm where they're at greater risk for poor outcomes from RSV infection due to a layering of these risk factors. So they have age-related decline in immunity, they have decreased function of their aging lung tissue, and they also have the presence of multiple comorbidities. So I have the common symptoms of RSV on the left here, and generally RSV is characterized by a gradual onset of productive cough and wheezing, although again, we can't rely on symptoms alone. And in terms of treatment for it, there's no specific treatment anyway, so prevention is the most important strategy. While the majority of cases, so 85 to 95% of cases are asymptomatic, the burden in older adults is high, as we mentioned before. So prior to COVID-19, RSV was actually the third most common viral cause of hospital admission in flu-vaccinated older adults who presented to the hospital with moderate to severe influenza-like illness. Within these hospitalizations, the rate of complications, the rate of readmission and mortality is comparable to flu, with 10 to 31% ending up in ICU, 3 to 17% requiring ventilation, and 1 in 9 patients dying. In patients with and without pre-existing cardiovascular disease, RSV infection has also been associated with exacerbations of heart failure, of arrhythmia, and MI, and not to mention exacerbations of the respiratory conditions like COPD, where you get an exacerbation, there can be permanent effects on your lung function. We also have prolonged morbidity, which we'll go into more on the next slide. And in the most severe situations, infection can lead to death. So this is a particular burden in older adults, where patients 65 plus account for 85% of deaths associated with RSV within hospitalization. And for older adults within over 75 years of age, 1 in 3 will die within 1 year of being hospitalized for RSV. So there's a lot of information on this slide, but ultimately the key point on this slide is that we're not just talking about that acute illness of RSV. So similar with flu, some of the main things that we worry about for our patients are the complications, the permanent impacts on their daily living and function. And before we move on to the next slide, I heard a quote recently from Dr. Vivian Brown that really stuck with me about RSV. And it's the fact that our patients may recover, but they will never be the same. So the long-term risks are illustrated well on this slide. 6 months post-RSV, both patients with high risk factors, as you can see on the left here, and those without high risk factors can have significant prolonged morbidity. The recovery time after a respiratory tract infection is long, with post-viral fatigue, weakness, and other symptoms. And even people with no comorbidities that have gone on to have 3 to 6 weeks of cough and long time to resolution. And within hospitalized patients, so this table shows outpatients, so non-hospitalized patients, either high risk or non-high risk. And then within hospitalized patients, 1 in 3 patients demonstrate persistent decline 6 months post-discharge. So let's get into the available product for RSV. And before we talk about this, we've heard reports from external physicians and organizations that there is some hesitancy in pharmacy in that sometimes pharmacists have been afraid to inject RSV because they're unfamiliar with it. And we hope that after this presentation, you feel a little bit more confident to provide this vaccine to protect your patients. So highlighting a couple of key characteristics, it's a single dose vaccine, it's a recombinant vaccine, it's adjuvanted, indicated for the prevention of lower respiratory tract disease caused by RSV in adults 60 plus. It has a high efficacy. So within the trial, the trial included about 25,000 individuals. It showed an 83% efficacy to prevent lower respiratory tract disease. And this efficacy went up further in patients with comorbidities to almost 95%. And it showed strong protection against both strains of RSV. So the way the vaccine is developed, it targets the fusion protein, which is highly conserved across RSV-A and RSV-B. And in terms of this is very high efficacy for a vaccine. In comparison, as a baseline to get approval for a vaccine in Canada, the efficacy threshold is actually about 20%. So when a vaccine is over 20% effective, Health Canada sees that efficacy as being worth it to approve. So we see here that there is very high efficacy. It's also adjuvanted, so it's helpful having an adjuvant in a vaccine similar to Shingrix to get a strong response within older adults, since there's generally a weaker T cell response. And it's shown in the data that in patients older than 60, 70 years old, there's still really good immune response regardless of age. And the adjuvant that's actually used in Arexvy is the exact same adjuvant that's used in Shingrix at half of the dose. There's also data to show that a single dose will protect for at least 2 years. So we have data for 2 RSV seasons at about 75% efficacy, and there's no booster recommendation at the moment. Another factor of Arexvy is that it is a Schedule 1 prescription. So prescription only, Schedule 1 product, so prescription only product. Pharmacists can prescribe and inject this in certain jurisdictions. So in BC, Alberta, and Quebec, pharmacists can prescribe and inject Arexvy. In Manitoba, Saskatchewan, PEI, Newfoundland, and Nova Scotia, pharmacists can inject Arexvy but can't prescribe. Now for PEI, Newfoundland, and Nova Scotia, I just put an asterisk right there for now, because generally pharmacists can prescribe in those provinces, but Arexvy has not been added to the list yet. So pending changes there. And in Ontario, pharmacists right now can't prescribe nor inject without a delegation. So a delegation would be a medical directive or a direct order. But we see that there can be impending updates there where it was submitted to have that be changed so that pharmacists could inject. But for the moment, we do need delegation. Some additional details about the vaccine. So in terms of contraindications, similar to other vaccines, it's hypersensitivity to ingredients. The main ingredient that can cause hypersensitivity is polysorbate 80. In terms of side effects, because it uses the same adjuvant as Shingrix, the side effects are quite similar to Shingrix and usually resolve in a couple of days. You have the local pain and swelling and systemic effects as well. And administration, it's the same preparation as Shingrix as well. So it comes with a liquid adjuvant and a lyophilized antigen, and then you will reconstitute it and inject when the patient is there. When it comes to coverage, right now, public funding is limited, and only in Ontario, there is some coverage for patients in long-term care, elder care, and retirement, but not in the community at this point.
So Molly, we have a question kind of related to that I'll bring to you right now. And it's about, how does one order the vaccine in Ontario? And can you just go back to that last slide?
Yep.
So like, it's the vaccine's listed in our wholesalers, and that's not for the public program. So that would be for individuals who are able to pay for the vaccine or who have private coverage. For the public funded program is very narrow in Ontario, and it's the only jurisdiction in Canada that has the vaccine in a public program, which is kind of novel because usually it takes a while before public programs pick it up. But in Ontario, our ministry and government decided to fund it for those in long-term care, elder care, retirement homes. But pharmacies are not participating in that program. Like a pharmacist potentially could if you were invited to come and immunize in the home. However, you wouldn't be compensated for that work unless I hired you as a consultant or something along that nature.
Thanks, James. I see another question as well. Sorry, my mouse is kind of lost here on the screen. About, is RSV virus mutating fast like flu? So does it need to be an annual administration? So for that question, because of the target of the vaccine, which is that highly conserved fusion protein, it has been shown that it is effective for both strains. And there is data to show that it provides coverage for at least 2 years. That data is continuing ongoing, right? So we may get additional data and expansion in the future. So we're not expecting this to be an annual vaccine like flu.
So there's a ton of questions about RSV, Molly. Maybe we should just address them now while we're talking about it. But does so you already kind of talked about the one about mutation. There was one about diagnosis. So how does one know if it's RSV? How do we differentiate from other illnesses, respiratory illnesses?
Yeah, so, flipping back to that chart that we showed in the beginning of the presentation, it's really difficult. And again, patients present with these conditions differently as well. And I think for us, in terms of the utility of actually diagnosing it or figuring out what it is, it's also limited because there's no treatment available for it anyway. In terms of testing, there are some rapid tests and it can be tested through PCR, but this is not widely available and will be available to us at the pharmacy level anyway. So I think the main point of RSV is more on the protection side and educating patients about their individual risks, as opposed to identifying it.
How often does someone need to get RSV?
So right now it's only a single dose and there's no booster recommendation.
But we're still collecting data out a few years, right? So
Yeah.
maybe it will change, but for now, as far as we know, it's just a one-time vaccine. A great question here around reactions. So is the likelihood of a local reaction with RSV similar to Shingrix or perhaps lower, given half the dose of the adjuvant?
Yeah, that is a really good question. I don't know if it's been directly compared to Shingrix. I believe it is similar. There was a co-administration study that I looked at recently as well, and the rate of side effects after co-administration with flu and RSV was similar to these two vaccines on their own as well.
So on the topic of adjuvants, so there's a comment here. I believe last year it was said there was no data to administer two adjuvant vaccines within a close time frame. Is this still so?
Yeah.
Shingrix
So
has an adjuvant in it. What should we be spacing RSV from Shingrix? My pharmacy doesn't administer COVID vaccines. Do they COVID vaccines have an adjuvant in it? So the last part, there is no adjuvant in a COVID vaccine. And I'll let you take the rest, Molly.
yeah, so no adjuvant in COVID vaccines. Around adjuvanted vaccines, that is still the case in terms of NACI, and most of the provinces are, I believe, acknowledge that there's very limited data. We know that, in practice it happens where patients may end up getting two adjuvanted vaccines together, but there is no trial data to show the side effects or the consequences of that. In terms of, in the absence of data, we can recommend, and we have in the past before, waiting 2 weeks in between doses. However, I would say that if the patient is at risk of not coming back for the vaccine, it's important to, make sure that they still get protected. And you can, at an individual level, have this conversation with them, and with informed consent. I think it's appropriate for co-administration.
If someone has already had an RSV infection, how long after that infection should they wait to get the RSV vaccine?
That is a really good question. I don't know if we have data on that actually, but there is data to show that there is a lot of reinfection with RSV. So I would say to wait at least until obviously the end of their acute illness before getting the vaccine.
I read that a patient can shed RSV virus up to 30 days after symptoms resolve. Any comments on that?
Yes, so especially for immunocompromised patients or older adults, that viral shedding can be quite long.
And this last question I have here is about co-administration, and we're on the slide about that. So can RSV be co-administered at the same time as flu and or COVID?
Yeah, right on cue. So there is data for co-administration with flu vaccines, as you can see on the slide. And there's right now we are in a place where NACI has not made comments on RSV yet. So we don't have NACI guidance, but ACIP or ACIP in the States, which is a similar entity to NACI here, advises that co-administration with other vaccines is acceptable, provided you have that one-on-one conversation with the patient and based on patient factors, like how likely they'll come back for a vaccine, what's their risk of disease, what's the patient preference. In the absence of NACI guidance, a lot of provinces are following general NACI guidance, which I've put on the left here. So in general, NACI says that all inactivated vaccines may be administered together at any time before or after other inactivated vaccines or live vaccines. So as this is an inactive vaccine, it should be safe. And that's shown with the co-administration with flu vaccines as well, that it's safe and effective. In terms of provincial recommendations, it's very limited. In Ontario, the ministry has come out to say that they recommend spacing between other vaccines by 14 days. However, there is a note here that patients can still receive the RSV vaccine with their other vaccines at the same time with informed consent. And again, that's that individual patient level decision-making where you let them know what the risks and benefits may be. In terms of risks and benefits, there isn't really a risk on efficacy. It's more about potential increase in side effects. A lot of other provinces that we took a look at have either not made recommendations or, as I mentioned, are following general NACI guidance, so allowing co-administration.
Yeah, Molly, I would add it's not unusual that the other provinces haven't made recommendations because they don't have programs that fund those vaccines.
Yeah.
There's one last question I have about RSV, and does it cover both A and B RSV strains?
Yeah, the efficacy, there's good efficacy for both strains. Okay, so as a summary for RSV, we put this into the why, the who, and the how. So why is RSV protection important? Number one, because it's hard to identify RSV from other respiratory infections and that it's easily transmissible. It's very contagious. And also testing is not readily available, so we can't really tell when someone has RSV and might pass it on to others. There's also no specific treatment available, so the best thing is to protect patients. And of course, as we mentioned before, there's high morbidity and mortality with patients with for patients with severe disease. So it's critical to prevent that infection and to keep patients healthy and to preserve their function. In terms of who's at risk, I think we've mentioned this many times. Older adults, again, the vaccine is indicated for 60 plus. So having older age is one risk factor. Being immunocompromised is another risk factor. Having chronic conditions are other risk factors. And again, those stack upon each other to have increased risk of severe disease. And how to protect against RSV. There's Arexvy, which is currently available as a single dose vaccine. It's IM. We're familiar with it because it's very similar to Shingrix in how you prepare it and administer it. And there's strong efficacy for patients 60 plus, especially those with chronic conditions as mentioned. And we should be recommending for patients 60 plus. So right now we have Arexvy as an option for RSV. There are upcoming vaccines from Pfizer as well. And those can potentially come up in the future as additional options.
Molly, there's another question here about RSV, and why are we talking about RSV so much this flu season and not in the past? And I think the obvious answer is we finally have a vaccine to address RSV. It's not that the virus is new. We've been struggling with RSV for years without tools to protect folks. So I think that's why the excitement.
Yeah, really good point, James. Like RSV has been in the community this entire time, right? And a lot of it's underreported because people think it's flu or they think it's a cold, but it does account for, and again, it's often thought of as a pediatric illness. But again, in terms of who's actually hospitalized and who dies from RSV, the vast majority are those older adults. So we're happy and excited to have something to protect our patients. Okay, so let's go over a quick review of COVID-19 and Paxlovid which I think will be very important for this upcoming season as well. We have a few tables that we've created, which might be helpful for your teams. There's a couple new products from Pfizer and Moderna targeting the XBB strain, which is the most dominant circulating strains now. We summarize some of the products on this table here, and we've kind of grayed out the monovalent, the original vaccines. Most of those vaccines by now are either unavailable, they've been phased out, or are expired. So we're mainly looking at bivalent vaccines and the new XBB, which is also a monovalent vaccine. Note that in terms of communicating with patients, it can be helpful to have less of an emphasis on booster dose this winter, this fall season, and more on talking about how it's continuing your protection against COVID with a brand new vaccine, right? Because this XBB vaccine, it's really a brand new vaccine. We're not counting doses anymore for anyone. It's basically after 6 months, your protection for COVID-19 wanes. So we want to make sure that you're continually protected with the newest vaccine that's targeted to the changing strain. We've put together this summary table as well in terms of, based on NACI guidance, what product is recommended per these particular age ranges, and whether or not they had previously received vaccination before, and a little information about dose timing. Note that, again, this is NACI recommendations. Provincial recommendations may vary, and to follow your provincial eligibility. This is a table of Moderna products. And again, some of the older products have been grayed out here, focusing more on Omicron, the bivalent vaccine, and the new Spikevax monovalent vaccine. So again, you'll get these slides after the presentation, so no need to write this down. We've also included some very, very helpful tables from Pfizer. And if you don't already know of it, go to cvdvaccine.ca. I'll include that in our summary email as well. That's probably the best hub for information about Pfizer COVID vaccines, and it has the most up-to-date information about expiry and about products. And these tables are updated as well. So just as a quick note here, in terms of the new XBB vaccine, Spikevax has the one product which, depending on age range, as you can see on this previous slide, there's different doses for that. And then with the Pfizer, there are 3 different products, and depending on age, you would choose the right product for the age. And for the maroon cap ones, you still must dilute these, versus the gray and the blue, you don't have to dilute. Pass it off to James for these next 2 slides.
All right, over to me. And I see we have a ton more questions about RSV, and maybe we'll park those for the end since we've moved on. But there is one here about bivalent versus the XBB, Molly. Maybe I'll give that to you before I dive in. So if you had a patient who was leaving on vacation for 4 weeks, would you give them the vaccine, the bivalent that you have now, or would you have them get the XBB when they get back?
Yeah, really good question. I think we're going to come across these situations in various different formats over these next couple of weeks, as we have this transition period where we have the bivalent vaccine, and we're also starting to get the XBB vaccine, which James will talk about in a minute as well. I think in these situations, we have to acknowledge that the bivalent vaccine, there still is efficacy against XBB with the vaccine. There is a boost with the new XBB vaccine. However, if you have a patient where they're going to be in high-risk situations, they're traveling, they're going to be at conferences with 100 people, they're going to be at Halloween parties, it may be worth it to get them the protection now. And then they can get whatever dose is available 6 months later, or whatever the next recommendation would be. So it's, at the end of the day, we want to protect them as much as we can from their personal risk, right?
Thank you, Molly. I wanted to depict with this slide what I think my average whole health pharmacy in Ontario what the pharmacy teams look like these days, as they send me these messages many times a day asking when's my XBB coming. So that's probably the most popular question I've been getting from our Ontario stores, especially. And it's been quite confusing. And like the messaging, often we learn about the deliveries after it's already arrived. So we know it's coming, but don't always know when. Molly, can you go to the next slide?
Yes.
This is just a bit of an overview of, the 4 provinces where we have the most number of whole health stores, what's going on. So when am I getting the XBB vaccine? Good news is most of our provinces already have it. And if you don't have it, it's coming very soon. So actually in Ontario today, we heard that in southwestern Ontario, the deliveries are starting to happen for our pharmacies. So it shouldn't be much longer until it's arriving in the rest of the province. But in case you're wondering, what's coming and what sort of communication you may have received already, if you're in Ontario, you would have received a welcome email from the vaccine supply and logistics at ontario.ca email. So search your inbox. If you haven't received that email, you should be able to find it. And in that, it tells you what your auto shipment would be. So Ontario's switched up the program for fall with the XBB. They're doing auto shipments, and they calculated quantities for every pharmacy based on your performance over the last several months in the COVID vaccine program. So all of you who have been actively participating will have auto shipment quantities, and every new pharmacy also should have some as well. So have a look for that email. And those deliveries were to be starting this week and just started landing in pharmacies today. And it's the Moderna XBB vaccine. Not too sure about Pfizer's supply for Ontario just yet. And Ontario's taken the position that pharmacies should be vaccinating individuals who are high risk of complications or hospitalization up until the end of the month before we would offer to the general population. So please keep that in mind. Try and get to your high risk patients first when you get those deliveries. And you'll see on the slide, BC and Alberta and Saskatchewan, for the most part, already have received Moderna XBB, and some provinces also have the Pfizer vaccine landed in them as well. So that's all I wanted to say about that, Molly. Thank you.
Thanks, James. Okay, so I see we had a lot of questions about co-administration of vaccines. I would just summarize some of the NACI recommendations and we can chat a little bit about it here. So again, data are limited regarding, and we talked about this before, regarding adjuvanted vaccines with other adjuvanted vaccines. The overall NACI recommendations for patients over 6 months is that all seasonal flu vaccines, including FluMist, may be given at the same time or at any time before or after other vaccines, including COVID-19 vaccines. Again, we talked about before, Ontario advising 14-day interval with the RSV. This is not a NACI recommendation, and most provinces haven't really commented or are not following that recommendation. And we've talked about it before earlier on the co-administration of Shingrix with adjuvanted or high-dose flu vaccines. There's no data on it, but it can be something that you discuss with your patient and with informed consent that it may potentially cause more of an adverse reaction. It can be something that is given, especially if you're going to lose the patient and they may not get the vaccines that they need. In terms of giving 2 vaccines or more, it's preferred to give vaccines on the same day. And you can use the opposite arm or separate by at least 1 inch. Although, like we always talk about using opposite arms, although, it's totally okay to use the same arm. And in certain circumstances, patients may prefer it because instead of getting one arm down the next few days, instead of having both arms down the next few days, you only have one. But overall, we do recommend, and NACI has this stance and Whole Health as well, to hopefully recommend to patients as many vaccines as they are recommended to get so that we can capture them, we can protect them as early as possible. Before we move on from COVID, I have a couple of slides about Paxlovid, and I won't go into all the details about Paxlovid because a lot of it in terms of what Paxlovid is and who's at risk hasn't changed. But I just wanted to express that, especially for the provinces where pharmacists can prescribe Paxlovid, which is, I've noted on the slide, Alberta, New Brunswick, Newfoundland, Nunavut, Ontario, PEI, Quebec, and Saskatchewan. It's really important to make sure that patients are aware that there is this product available that can help them if they were to get the infection. Often when you talk to patients, and even if you talk to your friends and family members, I think the majority of them haven't ever heard of Paxlovid, don't know that it's available. And especially for those patients who are at higher risk, who are older, who have complications or multiple comorbidities, we should aim to make sure that they know that if they do happen to get COVID, there is something that they can help. And in those provinces where pharmacists can prescribe, we can provide it to them. In provinces where we're not able to prescribe, it would be important to recommend it to their prescriber, for example. You can send in a request to have a dose be put on hold until the patient gets a positive test, so that because we have such a small window of 5 days, that no time is wasted. And some additional details about Paxlovid dosing, which you'll have when you get the slides later on. I know we're running short on time and there's still lots of questions, so I just want to go over the next couple of slides about common older adult vaccines that we see as well. So Prevnar 20 came in last year as an update to Prevnar 13. So the original Prevnar 13 had coverage for 13 subtypes. This one has coverage for 7 more of pneumococcal pneumonia. It's only a single dose, which makes pneumococcal vaccination a lot simpler than it was in the past. And there's no need, after patients get Prevnar 20, there's no need to get Pneumovax or any other pneumococcal vaccine. Now, if they previously received pneumococcal vaccines, NACI recommends waiting 5 years after Pneumovax or waiting 1 year after Prevnar. And on the right, we just made a summary of some of the NACI recommendations for Prevnar 20, in which they recommend that it should be offered to adults 65 plus or adults 50 to 64 with risk factors for pneumococcal pneumonia, or adults 18 plus with immunocompromising conditions. But I've also included that table on the lower left to provide a little bit more context for burden of disease, where we see patients who are aged 50 to 64 have that increased risk of pneumonia compared to healthy adults in the same age range. So you can see on the first row here. And same with 65 plus, we have that increased risk, but 50 plus, we also have that increased risk. So similar messaging with all of the other respiratory infections, it's really important to protect our patients' function. At an individual decision-making level, it would be appropriate to approach all patients 50 plus with this recommendation to talk about their individual risks and to protect them from pneumococcal pneumonia with the 1 dose of Prevnar 20. Another vaccine that is common for older adults that we should be recommending is Shingrix, also a very highly efficacious vaccine. It is a Schedule II vaccine. So compared to Prevnar 20, which is Schedule I, Shingrix is Schedule II, so we don't need a prescription, although that may be needed for private coverage in some circumstances. We should be recommending the vaccine for whoever it's indicated to. So it would be 50 plus or 18 plus if immunocompromised. And last year, Whole Health actually developed a tool to help with decision-making for immunocompromised patients with Shingrix, which I'll include in the email blast after the webinar as well. It comes in 2 vials for reconstitution. I'm sure everyone's familiar with it. And it is 2 doses given 2 to 6 months apart. Just as a note, a lot of people we hear it's missing that second dose. So they get the first dose and then they forget to get the second dose. It's really important that patients get that second dose to get the full protection from the vaccine. In terms of coverage for Shingrix, It's developed a lot within the past year. Originally, we only had private coverage in Ontario. Now we have coverage in Ontario for 65 to 70. This year, we still include ages 71 to 74 until the very end of this year because they missed it during COVID. But we also have coverage now for NIHB patients, 65 plus, Veterans Affairs patients, 50 plus, FNHA and BC for 65 plus in the Yukon for 65 to 79. PEI for 60 plus, Alberta for 18 plus if they're undergoing solid organ transplant, and the Canadian Armed Forces for immunocompromised patients 50 plus. And I've summarized some recommendations here around timing after they get shingles or after they get Zostavax, for example. We still want to protect them because the immune response after Shingrix is much more robust and long lasting than the immune response that they get after having shingles or after the previous vaccine, Zostavax.
So Molly, question before you move on, because I think it's important. You mentioned it's key to complete the series of 2 vaccines. And what if you were covering a shift in a pharmacy and you run a report and you find there's a bunch of patients from before COVID or a couple of years ago that got their first Shingrix dose, but then were lost to follow up? Like, what should that pharmacy do?
Yeah, really good question. This comes up a lot, in which we get this question about continuing the dose after a prolonged period. First of all, it's a great strategy to actually be running these reports to identify these patients to make sure they get the most out of Shingrix vaccine or any vaccine that's multiple doses. First of all, to find unfilled doses. And for Shingrix and for all other vaccines, every vaccine that has multiple doses, the recommendation is that you continue the series. You do not restart the series. You can continue to get the second or subsequent doses, and that will be fine, and the series will be completed. So there's no need to restart. Question. So taking a look at time, we had a couple of slides on best practices, but maybe we will provide these for you to read through. Miriam had wonderfully summarized some of the best practices around preventing vaccination errors, which we know with all of the vaccines that we're giving, it's really easy, right, to kind of forget some of these things. But as a quick reminder, and as a quick note for best practice, we get a lot of questions around this too. So drawing up multiple doses for flu vaccine from a vial. In terms of recommendation, it is not recommended due to uncertainty regarding product stability once it's been drawn up in the syringe. So ideally, you should be drawing up the vaccine and administering it right away for flu.
Yeah, Molly, before you completely abandon that part, like I want to just call attention that in Ontario, there's been complaints of patients receiving a bivalent COVID vaccine and thinking that they're receiving the XBB updated COVID vaccine. So just make sure that patients know which vaccine you're providing them and they're consenting to that, because it's not worth the difficult conversation afterwards if they're disappointed that they didn't get the vaccine they thought.
Mm-hmm. Yeah, I mean, there's still a lot of selection at times for COVID vaccines, not as much like for flu and some of the other vaccines, but at the end of the day, it's important to be, upfront with patients. And, again, as we mentioned before, it's okay to get either vaccine, XBB or bivalent, but making sure that the patient is aware and you have informed consent. Okay, so I have a couple of slides on implementation, and then we'll get to some of the questions that have been coming in. So we put together this summary of key vaccination recommendations per age group. And this is something that, it could be something that you add to your consent forms too, like we have at Whole Health for our pharmacies. And it could be something that you involve other immunizers like our technicians, our students as well, and other pharmacy team members to help flag these patients for the pharmacist. So on age alone, there are vaccines that we should be recommending or at least speaking to our patients about. So for under 18, HPV, meningitis B, adults 18 to 50, again, HPV or meningitis B based on those age ranges. Shingrix and Prevnar if immunocompromised, Prevnar 20 if chronic disease. 50 plus, we're looking at Shingrix and Prevnar 20. And 60 plus, we now have the addition of RSV as well. And regardless of age, so in every single group, we want to consider the annual flu and make a strong recommendation for that. We want to recommend the latest COVID-19 vaccine if they're eligible. Everybody needs to get a tetanus booster every 10 years. And during pregnancy, we also need a Tdap vaccine. A quick summary of opportunities within the pharmacy workflow too. So we went over who previously on the last slide, when there would be multiple opportunities for this. So there's passive screening opportunities when patients are booking, if you have a booking system, or when they're checking in and they can self-identify if you put up signage around it, and if you include some of these questions in your consent forms. When they're waiting, you can have materials in the waiting section so that they can see that it's not just about COVID, it's not just about flu this season. There's additional vaccines that they can really benefit from based on their age, and during vaccination as well with your discussion with the patient. One of the things that I always think about, we did a webinar on meningitis B several years back, and you know, a couple of years ago, there was a boy in Nova Scotia who had died named Kai Matthews. And one of the things that his parents had brought up after his death due to meningitis B was that nobody had ever brought up meningitis B vaccine before. Like some of these other vaccines like Prevnar 20 and Shingrix and meningitis B, they're not often included in the public program, but that doesn't mean that you can't have benefit from them. And it doesn't mean that we shouldn't talk about them with our patients. So the cost of a vaccine or any treatment shouldn't be a barrier for us to recommend it for patients. In terms of how to do these recommendations too, again, as I mentioned, posters, pamphlets, handouts, bag tags. You can use technology if you have them. Some of these booking systems or pop-ups or reminders for patients. And I won't go through this in depth, but there's at each point in the immunization workflow, there are small things, quick things that you can implement, passive things to help remind patients, remind your staff about vaccines. Okay, and that brings us to the end of our presentation, and we're right on time. We have a minute. But we'll stay on for extra questions.
Wow, that's great. Thank you so much, Molly and Miriam, for taking us through that. And we have a real mixed bag of questions. And I hope folks will stay on to hear the answers. But if you have to go, no hard feelings. I did put a link to a feedback survey in the chat. If you would fill that in, it would be very helpful for us, just to make sure we have the right touch on these presentations going forward and getting you what you would like to see and hear on various topics. So maybe I'll start at the top of the list, Molly, and just work our way through all these questions.
Yeah.
And feel free, if anything else comes up, you can keep adding. We'll stay on for a bit. So if an individual gets RSV vaccine after they got the disease, would there be any side effects or issues because there's no reliable test? Maybe they had RSV and didn't know.
Yeah, good question. Not that we know of, right? There's a lot of reinfection with the disease, and we definitely want to protect them from the vaccine. So I think it's more about identifying the patients who are at risk and providing the vaccine versus trying to figure out if they've had the infection before, like similar to some of the other vaccines that we get with COVID or with flu, right?
So the next one is, can we inject RSV vaccine? And is there any clear difference of diagnosis between RSV and flu?
Yeah, good question. So depending on which province you're in, so Abby, in Ontario, right now, we cannot inject RSV vaccine without a delegation. So a delegation would be a directive or a direct order. That may change soon as that amendment to the regulation has been submitted. We may see a change soon, but right now we cannot inject it. Pharmacists in other provinces outside of Ontario can inject it, and some provinces, which I mentioned before, can prescribe it as well.
And I'll say pharmacists and technicians. So like I think sometimes we forget that our technician peers are very important in this role, but either would need a delegation in Ontario right now, and it's not as complicated as you would think. You just have to have the doctor write pharmacist to inject or pharmacy technician to inject. And I said doctor, but I meant prescriber because it could potentially be like a nurse practitioner, for example. So, and we're expecting regulation changes, as Molly said, in the coming weeks in Ontario that would change that, where pharmacists would have the ability on their own authority to inject. However, they would still need a prescription. So for those who did COVID vaccination for the kids in Ontario before, do we need to order it? Or will it be auto-shipped at the beginning, same as adults? So Molly, I think that's a question more from me. So Jose and I have not seen anything about the pipeline for pediatric XBB vaccines for COVID. You might have noticed that the Moderna one is available to be used for children as well. So you could offer them that. I assume that the government also ordered the Pfizer for kids, but we don't know. It's not a part of the auto shipment. So you would probably need to order it once it's available. The next question is, why are some doctors reluctant to prescribe Paxlovid? I'm not sure if that's the right audience to ask that question too, but Molly, any thoughts?
Yeah, I mean, I can't speak on behalf of doctors, but we do know as a fact that Paxlovid distribution in community is not as uptaken as it could be and as it should be with the amount of at-risk patients that we have. I think Paxlovid prescribing can be very complex or it can seem very complex due to the multiple drug interactions, which maybe that's why there's some hesitancy within some healthcare professionals and the time and the expertise needed, but there's lots of tools out there. So definitely use the DI checkers. There a lot of tools now are very comprehensive. And I think as pharmacists, there's 8 provinces in Canada where pharmacists can prescribe Paxlovid. And as the drug experts, we really have a role in being able to help patients navigate the getting access to this medication and making sure that it's safe with the drug interactions, which are our expertise, right? So definitely we can feel empowered to prescribe.
Yeah, and there's still we need to do work on awareness. There's still a lot of patients who are unfamiliar that Paxlovid is appropriate for them or would be useful when they catch COVID. I keep encountering individuals I would think would know of that therapy by now, but actually they get COVID and they don't even think to ask. And they have pharmacists that are friends and they don't even think to ask. So imagine your patients. Like, we need to keep it top of mind with our patients. Someone asked me, where is the survey? So I put the link in the chat. So if you click chat, you should be able to see the link for the feedback survey. Questions around Prevnar and Pneumovax. So Molly, if a patient had Prevnar 13 and Pneumovax 23, do they still need to take Prevnar 20? Or I would phrase it, would they benefit from Prevnar 20?
Yeah, good question. They would certainly benefit. I mean, if it was Pneumovax, for sure they would benefit because it's a conjugated vaccine, which is more recent technology. It's got great coverage for the strains included in it. I would definitely recommend it to patients who have previously received Prevnar 13 and Pneumovax.
Okay. I think this question is just in general about vaccines. So if a prescription is needed for private coverage, so I think this maybe would be like a Schedule II vaccine, Molly, kind of pharmacists prescribe it.
Yeah, so the way it works in provinces is that if pharmacists are not a designated prescriber in the province, then technically we're not able to write a prescription for that vaccine, even if it's not a non-prescription vaccine. And I mean, in terms of practicality of that, there's certainly, we can have a long conversation about it, but there can be obviously advocacy done on our end to be able to have pharmacists remove some of those barriers for patients, and hopefully that is on the horizon.
So the next question here is about what I call the infant COVID vaccine. So what's like the youngest age a pharmacist can immunize against COVID? And for Ontario, and here in Ontario, we put through like it was an urgent regulation that allowed pharmacists and technicians to administer COVID vaccines as young as 6 months old. Not every pharmacist took us up on that. It was kind of an opt-in sort of program. I think we had a handful of whole health locations offering that as vaccine as low as 6 months. So you certainly can offer the age-appropriate vaccine as young as 6 months. Good question around Tdap, Molly. Do we recommend Tdap for every pregnancy?
Yes, so for each pregnancy, we want to get the Tdap vaccine, and I believe there is coverage for it within provincial programs, and you want to recommend to the individual who's pregnant to get the vaccine at around 27 to 32 weeks of gestation.
Okay, switching over to meningitis. Does meningococcal ACWY vaccine replace meningococcal C vaccine?
Yeah, so good question. So a lot of provincial programs will include meningococcal C vaccine. I think in younger infant vaccine schedules, the ACWY is also received. And also we get a booster of ACWY at around elementary school, grade 7, grade 8. Definitely doesn't replace it because Men-C only has the C strain, whereas ACWY has the 4 others. And especially where if you're traveling, or if you haven't had the ACWY booster before, it's important to get that vaccine also. But yeah, travelers to the meningitis belt in sub-Saharan Africa should be getting ACWY.
Okay, so just a clarification request, Molly. I heard you have mentioned Pneumovax not required if someone chose to take Prevnar 20. Did I hear that correct?
Yep, so Prevnar 20, I don't know about you guys, but a couple of years ago, I found Prevnar pneumococcal vaccines a little bit difficult to remember. And it was always very challenging around the timing, and like you had to get this vaccine and then this vaccine after. Prevnar 20 makes it a lot easier now, where there's one single vaccine. It is the one dose, you get the vaccine, and you don't need any other pneumococcal vaccines in the future. Potentially that could change. Potentially there could be data to show boosters in the future. We don't know at this point, but right now there's no other pneumococcal vaccines that you need.
So if a pharmacy received a prescription for Pneumovax, should we be switching it to Prevnar? Like recommending a switch?
Ideally, I would recommend a switch to Prevnar 20. It is the better vaccine. Patients may continue to want to get Pneumovax because there's provincial coverage for Pneumovax, whereas there's no provincial coverage for Prevnar 20. But even in those situations where an individual had Pneumovax before, the length of immune response isn't as robust and long as it could be with a conjugate vaccine like Prevnar 20. So even though in those situations, it's still recommended for the patient to get Prevnar 20 after Pneumovax anyway. So just skip the first vaccine and you can get Prevnar 20.
Yeah, I was wondering we could save one poke if you get the Prevnar 20. So the last question there that I see is thoughts on HPV vaccines for males over 50. Is there any indication for it? Should we advise against it?
Yeah, good question there. So as you guys recall, the indication for HPV is 9 to 45, although there is an asterisk there in that, even our guidelines say that it could potentially be considered for patients over 45 if they have that ongoing risk of HPV. And again, like we think about HPV vaccine as not just a vaccine to prevent against HPV infection. It's really a vaccine that protects against cancer, right? So it's a cancer vaccine at the end of the day. So if your patients are at risk for HPV, And, in the past, like this was all often thought of as a very gendered vaccine. HPV can affect everyone. It can cause cancer, not only in cervical tissue, but also in your head and your throat, right? So, in fact, the rate of oropharyngeal cancers in male has risen, even surpassed cervical cancer. So definitely would consider the HPV vaccine even beyond age 45, especially if the patient continues to, is sexually active, or let's say you have an older adult who started dating, right? Like they could be at risk for catching HPV, which could lead to
Yeah.
cancer.
I was thinking like a newly separated person who's no longer monogamous with one partner. I know we label this as a sex vaccine, but it really is a cancer preventing vaccine, and sex happens to be a risk to getting that virus. So I missed one question earlier in the discussion, Molly, and it was, what if a patient is 59 years old and they're on a immune suppressing medication? Should they get the RSV vaccine?
Yeah, so good question there. We can definitely recommend, okay, technically like it's off label, right? So it's indicated for patients 60 plus. And so we could recommend it to the physician or whoever the prescriber would be, and it would be their judgment to be able to write that prescription for the product. But age 59 versus 60, there's probably still a really good benefit the patient would get, especially if they're immunocompromised. And we potentially could see prescribers doing that for some of our patients, even under the age range.
Some really interesting questions keep coming, and I see our audience is holding on, so we'll carry on with the questions, Molly. But how soon should an compromised patient take Prevnar 20 after receiving both Prevnar 13 and Pneumovax 23?
Yeah, I don't know if NACI has made specific recommendations around immunocompromised patients, but in general, we want to give the new Prevnar vaccine 5 years after, or they recommend providing the vaccine 5 years after Pneumovax 20 and 1 year after Prevnar 13.
And there's a question around the age of Prevnar 20. I don't know if you want to bring that chart back up, Molly.
Yep, so Prevnar 20, oh, sorry, yeah. Let me go back to the recommendation.
And some of these questions, Miriam's been politely typing the answers, so please have a look if you got a typed answer rather than a live answer.
Amazing, thanks, Miriam. So Prevnar 20, again, indicated for ages 18 plus, but really we want to focus on some of those high-risk patients, especially 50 plus.
Yeah, so everyone 50 plus, but individuals with risk factors in younger age groups. But generally, if you've got a patient in front of you and they're 50, after their birthday, you should be asking them, hey, let me tell you about Prevnar 20. Let me tell you about Shingrix, just to make sure they're protected. And, there's some clinicians will advocate delaying to later in life when they might be more likely to get pneumonia or to get shingles. But, years down the road, we might actually be boosting for those same conditions. If that person has the longevity to go from 50 to 80, maybe we'll be changing our philosophies around vaccines at that point. So I would protect them now, because you never know when shingles or pneumonia might catch that patient, and you have an opportunity to help them today.
Yep.
So if not known regarding HPV vaccination, is it okay to recommend getting it?
That's also a really good question. And we did vaccine research within the banner. Well, we've done a lot of vaccine research, but in one of our projects, we were taking a look at making vaccine recommendations. And oftentimes vaccination history is something that we don't know, patients don't know, prescribers might not know as well, right? So that vaccine history is really hard to nail down at times. And I would say to that question, there are a lot of healthcare professionals and vaccines who would agree with me that, if you don't know whether or not they had the vaccine, it's still worth it to provide the vaccine so that they get coverage. In terms of safety, there aren't too many safety risks with providing a vaccine if they already had it before, but at least you get them the protection.
Yeah, and if it gives you any comfort, Jazz, I had to repeat my whole vaccination series because Nova Scotia threw out my records, and I went to pharmacy school in Ontario, and they needed vaccine records, so I had to repeat everything. So I'm still here. That's your N of 1. Well, I think that's it, Molly. So I will leave it for you for just final comments.
Okay, thanks so much. Really appreciate everyone staying on tonight and joining us. We had a great group, lots of good discussion. Hopefully you found this session helpful, not just for flu, not just for RSV and COVID, but all of these vaccines that we really should be considering for all of these patients based on the age on the screen here. If you have any further questions, feel free to email myself, and I'll be following up with everyone who joined in and registered with the slides, some additional resources, and the recording as well, in case you'd like to review. But other than that, thanks very much, everyone. Really appreciate it.
Thank you, everyone. Have a great night.
Okay, thank you. Take care.
Thank you. Bye.